a little over a year ago. So I'm glad to be back and talking with you all. I don't really like to just stand up and lecture. I like to have audience participation. So I thought this would be a good opportunity for me to get all of you involved in this session. So I'm aware of aging. Well, we all, each and every one of us, age every single day. And what I have come to learn over the past 14 years, but I think I've known longer, is that age is just a number. That's really all it is. But so I'm supposed to talk about normal aging. That is a very interesting question. What exactly does that mean? What is normal aging? So we all know that there's a lot of issues.
House, first floor,
Hold them back. That was Crane. We know that there's a lot of issues that are common as we get older. And one would say, are they actually, is that normal? Well, that's an interesting question. I think that just because of us being alive and all the things that we do, it takes a toll on the human body. And we know that our genes feel that way too. Our genetic, not our genes, but our genetic genes, they change as time goes on. If you go back, thousands of years, for human beings, humans did not live as long as we do now. So I think that it kind of makes sense that now that healthcare is improved and we're living longer, think about it, all the walking and everything we do puts a toll on our bodies, on our joints especially. So is it normal to have more aches and pains when you get older?
Yeah.
Is there a single person here who has not woken up in the morning with an ache or a pain? Ever? Well, what's your secret?
Just trying to be tantric.
Yeah, so I wake up now at, very often I wake up in the morning and I'm like, oh my gosh, and I just have to loosen up. And then as the day goes on, it gets better. So yes, I think that has become, that's a common thing. It is not unusual for us as we get older to have more aches and pains. Certainly there's different degrees of aches and pains, and there's a lot of different factors that play a role with joint issues. And we'll talk more about that. But before I go more into issues like arthritis and pain, why don't I have some audience participation? Why don't just shout out, what are some other issues that come with aging?
Hearing,
Balance.
poor vision.
Yeah, so I hear lots of sensory impairment, sensory changes in vision, changes in hearing. I heard balance changes. I heard needing joint replacements, which goes along with the osteoarthritis. That's the wear and tear arthritis. What else? What are other issues associated?
Dental.
Yes, dental. Skin, yeah. What sorts of skin issues?
Sagging. Sagging. Yeah, physical.
What is
Sagging.
Oh,
Sagging.
sagging, that's a good one. Wrinkles, skin cancers.
Yeah.
Just normal spotting, the stick-on lesions we call seborrheic keratoses.
Keratosis.
Yes. Yeah, skin tags. What else? Any other issues? I haven't heard a big one. Thank you. That's the one. Yeah, well, mobility for sure and balance. And then memory. I was kind of waiting for that one to come out.
He said it.
Oh, you said it? I'm sorry. I missed that, but thank you. Thank you for, I was waiting for that too. And that's always the classic though. Okay, I think we covered a lot of them. There's one other that I'm thinking of.
Getting up at night many times.
Okay, yeah, oh, actually, now you mention it, there's a few others in insomnia. Our sleep cycle, changes as we get older. Our REMs, so as we get older, our REM sleep decreases. So that is a usual expected part of aging. Sleep issues, I heard something else.
Lots of family and friends.
Yes, I hear that all the time, you know, that as I get older, I start going to more funerals, you know, unfortunately, and you start seeing your family members pass on and friends. So grief, I think grief is a part. And maybe going along with that, some mood issues, you know, having a tough time adjusting to changes in independence.
And loneliness.
Loneliness, you know, because we, often, I think one of the greatest fears of many of my patients is losing independence, needing help. You know, I'm sure a lot of you, we know we're a part of the Judson community and we know that we have other levels of care available to us, but yet still, you know, we don't necessarily want that. You know, we don't hope that we're going to need to be in assisted living or a higher level. Except me, I can't wait to move into assisted living. I don't ever have to cook or do anything like that. So loss of independence, needing more help and being more dependent on others is something that very often happens as we get older.
It's loss of control over your life in general, you know, when your kids become your parents.
Yeah, aging it's a very interesting life cycle, where, you know, we raise our children, you know, when they're growing up, and then we see the opposite happen. And I think that in and itself is very hard for people to deal with. You know, that comes with the lack of independence, but and being dependent, but it's hard to know that, you know, to feel like you're a burden to your family. I'm sure a lot of you have experienced this, but it is something that is very common. Other issues common with aging, I would probably add feet issues, potentially toenails and feet problems. I would add maybe bone issues, especially for women. You know, osteoporosis is extremely common as we go older, but you know, men get neglected when it comes to bone health. It is not routine in our country to screen men for weakening of their bones, but I think it's starting to become more mainstream now that even men, especially after the age of 75 and 80, men are also at risk for osteoporosis. Men get fractures too. Yeah, and that's another thing we all worry about, you know, that dreaded hip fracture, falling and breaking our hips, which comes along with the balance impairment, with the bone weakening. Gosh, we could go on and on and on, can't we? There's so many different issues. So what issues are most on your minds right now? Because honestly, I could talk for hours. We could talk about many different topics. But name just a few that you really want to discuss today.
Fear following.
Okay,
Yeah.
yeah. Anything else?
Appetite changes, we haven't talked about.
Yes,
And I think that's a big thing for a lot of people.
we did not mention that, and you're absolutely right. Changes in smell and taste, changes in taste, appetite. Yes, that is a big one.
I think mental issues are the most, my mind,
Cognitive issues, memory.
being able to think, brains shrink,
Mhm.
people lose their memories.
And one thing that I had hoped and wanted to do back when, like a year ago when I started, I came here to introduce myself, the plan, the hope was that I would do quarterly, talks. And then it kind of fell through the cracks. It didn't end up continuing, but I would love to come and do that on a regular basis. Because really, a lot of these topics that we're talking about today, they really need more than just 40 minutes. So hopefully I can come back to you, and talk with you all. We can talk more about all of these issues more in detail. Today we'll just kind of start to cover them. I know at the Manor, last year I went a few times and I did a session on memory, a session on falls. There's so much we can talk about. But today we're just we're getting it all out there and realize that aging may not necessarily be fun. We discuss all of these different issues and problems, and it's like, oh my gosh, wow. Yes, it is. I love that. It is, aging is not for sissies. But you know what? You all are doing it gracefully. Some days it may feel like you're not, but you are. And you know what? There is no right or wrong way to age. You just, and each of us are individuals. We each go about it in different ways, and we each have, some of us have some problems that are worse. Okay.
Hi, Blair.
Some of us have some problems that are more prominent for us than other issues, and other people may have more other different issues. You know what? We have to take what comes at us and we deal with it. And having someone who gets it, and a team of whole healthcare providers that get it is what's really helpful. And just remember, you're not alone in everything you go through. And the Judson team here is just absolutely fantastic. They are, they really do try their best to address all of your concerns, and all the different activities that you have here are wonderful. It's really great that there are resources available if you need them. There's downtown at the park. There's the skilled nursing unit if someone needs rehab, which is where I am the majority of the time. And of course we have Crane House. So we have this great community here. So let's talk about, I know I don't have too much time, but let's talk about some of these topics that are really on your mind. So the first that I heard was falls and balance. So what contributes to falls? Why does our balance change as we get older? Why are we more at risk for falling?
Inner ear.
Yeah. You can name a number of things and it'll all be correct. So the thing in my field, in geriatric medicine, what we talk about when I teach, when I educate of issues that are common in older adults, we often refer to them as geriatric syndromes, because they're not a single disease or disorder. It's a problem that are multiple factors contribute. And for falls, there are many different risk factors that contribute to falling. what do you think is the greatest predictor of having a fall?
Obstacles in your apartment or house?
Both of those are definitely risk factors, but the number one predictor of falling is having previously fallen. So, yeah, I guess I didn't mean to be, no, I didn't mean to be tricky, but it's true. Prior falls is the greatest predictor. But then other things that contribute, let's go through all of them. So you said inner ear, you know, our inner ear, system, is what tells our brain, where we are in space. You know, that right now my head is straight up, but if I go like that, my neurons just fired to tell me that my head is tilted. But we have little crystals in what they're called semicircle canals. There are these 3 little canals in our ears that, the crystals move when we move our heads. And that tells our body that, okay, we're off position a little bit. But if those crystals get out of whack, and don't fire the neurons appropriately, you move your head in a certain position, you can get vertigo, that spinning sensation. So inner ear problems definitely plays a role. Yes.
Vision.
And vision absolutely plays a role and increases risk for falling. This is an interesting point. What type of lens you think is the greatest using, what type of lens is the greatest risk for falling when walking downstairs? Yeah, bifocals. If you think about it, I kind of get sick to my stomach when I think about putting bifocals and then, trying to figure out what part of my lens to look at when I'm going down the stairs. So bifocals actually, believe it or not, do increase risk for falling, especially when you're trying to judge, depth, because it affects your depth perception. So if you're someone who has had falls in your home and you have stairs, maybe it might not be a bad idea to have a pair of unifocal glasses that you can use when you're walking around your house. So yes, absolutely, vision is an issue. And as we get older, we have greater risk for age-related macular degeneration, for cataracts, and for glaucoma, all of which affect our vision. So that's 2 things, vision, inner ear, which affects the balance. Yeah, posture, absolutely, posture does. So if we think about our neurologic system, in our brain, we have areas of our brain that affect, they're really trying to, I should have told them not to call me when they came over here. So in our brain, it controls the strength of our body, and also controls our balance. So we have a balance center in the back of our brain. So as we get older, one thing that is known to occur is our brains get smaller. So if you talk to a neuropathologist, if you could look at standard brains as you get older, at different ages, and it is clear that brains, they atrophy, they get smaller. And that is part of the reason that we do slow down. Our bodies slow down, our thinking slows down. I hear people say, oh, it takes longer for me to do the things that I used to do. I can still figure them out. I can still problem solve, but not as well as I used to. And it's not uncommon to see, as we get older, to see other changes in our brain. The blood supply, there's deep areas of the brain that don't get blood as well as others, and that can lead, it can affect other parts of the body. So, so what I'm trying to say is that changes in the brain can affect our balance, can affect our muscle strength. It can affect, our thinking, which cognitive issues increase risk for falling. So if you see a lot of these problems that we have as we get older, they all interrelate, and they all kind of contribute to a lot of the problems that we face. So other fall risks and factors that contribute to falling. So what is the first thing that I guess I said, does anyone wake up not hurting? Arthritis. Arthritis plays a big role in our risk of falling. So if you are having a flare of some sort of pain, you're having trouble with pain, does that make you want to move? No, it makes you not want to move, which means the less you move, the more likely you are to fall, because we get weaker. When we are moving less, our muscles get weaker, our joints get stiffer, and that actually increases risk of having a fall. Let's see, what else? So, yes?
It's related to the nerve, but neuropathy.
I was literally just about to say that, so you were reading my mind, because I was going back to the nervous system. So yes, neuropathy is something that happens commonly, especially affecting our feet. Why? Well, one is diabetes. Diabetes is a common condition. Elevated blood sugars over time can affect your nerves, particularly the nerves in your hands and your feet. So some people have neuropathy from diabetes. A lot of people have, without even realizing it, their feet, the sensation, the reaction time may not be as good as it used to be. Often actually because of the spine. I think that it is extremely common to see changes in the spine as we get older. So this kind of goes along with the bone issues, but our spines have a curvature. I don't. It kind of makes me sad in a way, but have you ever seen diagrams, drawings of the skeleton as with aging, and it goes from upright to like this to like this? And that is because of bone health. That is because of weakening in the bones. And as I guess it's from gravity and from wear and tear, but our spines start to compress, and the vertebrae get closer. Also, there's wear and tear of the little cushions between the vertebrae. And so spinal issues is what affects posture, but that also, the nerves that come out of the spine that go to different parts of the body can get compressed. And that can lead to pain, like a sciatica that we hear about, but it also can affect, especially the nerves in our feet. So that adds to the picture for falls. Well, what else? There's something that I am very guilty of, that your doctors are guilty of, but
just not paying attention to what we're doing.
yes, yeah, absolutely. So the environment. The environment is a risk. Somebody mentioned like stuff running into things. I think you had said that. What room in the home has the greatest frequency of falls? It's the bathroom. It's the bathroom. Why?
Because you're getting up from the toilet.
Yeah, because there has to be rugs, because usually it's throw rugs, and they the teaching in our falls clinic that we do at UH is you really want to avoid any kind of throw rug, any kind of rug that you can trip over the edge. But in the bathroom, if you don't have rugs and you've got cold tile, that if it gets wet, it's really slippery. So there's that factor. There's also the waking up in the middle of the night and having to go to the bathroom, and it may not be quite as light as it is during the day. And you're tired. You don't want to be up going to the bathroom in the middle of the night. You're tired. Yeah, yeah, and then of course the tub in the shower is wet. So the bathroom is the riskiest place in the house. But then, you know, we add other things that we can trip over. Animals, sometimes, cats, dogs that pull us down, cords, boxes, and, you know, adding the vision impairments and the balance impairments, and then maybe it's somewhat that you're not paying attention, but it's a combination of everything that plays a role. So I was asking, what are your doctors guilty of doing in this issue of falling? What do doctors seem to love to do? Prescribe medicine. This is this terrible cycle that I guess probably happened maybe, you know, started decades ago as we started having more and more medicines. It kind of just became a habit, a reflex, that if you have a problem, I'm gonna prescribe you a medicine. But guess what? I prescribe a medicine, and then in three months or so, person comes back with a new complaint. What do? I prescribe another medicine for that complaint. And then 6 months later, there's another complaint, and they get another medicine. But what doctors don't think about is maybe the complaints that the person came in with was actually related to the first medicine I prescribed. And then the new complaint was due to the second medicine I prescribed. So in geriatrics, I teach a couple of things. Less is more. And then also, if you are going to start a medicine, go low and start low and go slow with the medication. And also, if I have a patient coming in with a new problem, I first think medicine. Is there like a medicine contributing to that problem? So the reason I mention this is because there are many classes of medicines that independently on their own increase risk of falling. So like your anti-anxiety medications, your antidepressant medicines, seizure medicines, neuropathy medicines like gabapentin and Lyrica, sleep medications, and then what we call in medicine anticholinergic. Anticholinergic medicines are anything that tends to make you sleepy or is used to dry things up. So Benadryl, sinus medications, nausea medications, even a lot of the incontinence medications, anti-spasmodic medications for the stomach, muscle relaxers. Those are all anticholinergic, and they all increase risk of falling, and they affect memory too, memory and thinking. So when I see patients in my multidisciplinary clinic, falls clinic, one of the first things that I do is look at their medicines. And I look and see, is there anything that could be contributing, adding to their risk of falling? And I try to make suggestions to change. So that's something that's important to keep in mind, is that the falls are not necessarily always your fault. There could be things that your doctors are giving you that are playing a role. And you should bring it to their attention. Dr. Lathia said so. Trying to think of other factors. There's so many things that contribute to falls. Another one is our heart. You know, so we didn't talk about it. Maybe we should have said, you know, changes in our cardiovascular system happen with aging. You know, high blood pressure is extremely common as we get older. Atrial fibrillation is common as we get older. So lots of us are on blood pressure medications. So we're on blood pressure medicines. However, as we get older, and our bodies are used to being on blood pressure medicines for many years. Sorry, that came out wrong. Our bodies are used to having high blood pressure for many years, and our arteries adapt, they become stiffer, they don't relax as well as they used to. If we start to give a number of medicines to really try to bring that blood pressure down, what happens to a lot of people? They don't feel good. They don't feel good with their blood pressure being lowered. They feel tired. They feel lightheaded or dizzy. And then there's that big problem that definitely leads to falls. And that's the problem of standing up real quick and whoa, whoa. Like, people call it woozy. They call it dizzy, lightheaded. It's what we call orthostasis, meaning that when we stand up from sitting to standing, or going from lying to sitting to standing, our bodies need time. As we get older, our bodies need more time to adjust to that change in the change in position. Our veins, leg swelling. We didn't talk about that. We could have added that to the list. Leg swelling is a common problem as we get older. And part of the reason it is common is because our veins are not as good at bringing the blood back to our heart. So when we stand up real quick, our body, our legs haven't had time to adjust. Our bodies are not as good at getting that blood up, and our body, brain can't react as quick as it used to say, oh, you need to keep that blood pressure up now that you're standing. And so it takes us longer. Our pressures often drop when we stand up. That increases risk of falling. So that's, one of the things I will check when I have a patient who tells me they're, having imbalance issues, they're having lightheadedness, they're having falls. I will check their pressure in 3 positions: lying down, sitting, and standing. And I do often see that the pressure drops when they stand. And so that's adding to fall risk. And it could be that maybe we're doing too much blood pressure medicine. So as we get older, the way that our bodies handle medicines change. Our livers are not as good at metabolizing the medicines. Our kidneys are not as good, in getting rid of the medicines. So as we get older, we tend to need lower doses than people who are younger. And even perhaps medicines that we've been on for years and years and years, maybe we needed higher doses earlier, but as we get older, we're starting to feel the effects of the medicines more adverse effects. And so maybe lower doses would be better. So that is part of the reason that, maybe we really don't want to overdo blood pressure control as we get older. We have different goals, for people who are, especially in the 80s or above, that we tolerate higher blood pressure than we would for someone who's in their 30s or 40s. So lots of these issues that come up, if you can see that really all of the different factors that you mentioned to me of things we experience when we get older, they interrelate. You can see that a lot of these factors contribute to falling and contribute to balance. Let's see, we have a few minutes. Yeah, so
What about, what to do about it?
yeah, that's a good question. The question was what to do about it.
Don't grow old. Sit on the couch.
I hear, yeah, don't grow old, sit on the couch. I like that. Well, that's a good question. I think the most important thing that we all can do is to stay as active as we can, because exercise really does make a difference. Studies have really shown that regular exercise, even just walking, really helps reduce risk for falling, for arthritis issues, and also for it helps decrease the likelihood of needing more help. You know, the usual recommendation is to aim for walking 30 minutes a day, 5 days a week. If you think about it, you know, it doesn't have to be strenuous. It doesn't have to be, you know, really brisk walking. It could be just, you know, walking through the campus, you know, enjoying the beautiful gardens and paths that you have. It could be walking here, you know, within the community center and doing a couple of laps. That's really not hard to do. But I think that that is something that is really helpful. The other thing is staying socially active. So you have this community here where you have tons of activities that are available. I think that's wonderful. You want to keep your brain active by talking to other people. You also want to challenge your brain, you know, mental stimulation. It can be helpful. So we didn't really get to talk about the memory issues in detail, and I'm happy to come back to do that. But when we talk about memory issues and thinking issues as we get older, the best thing you can do to challenge your brain is something new. You know, that's just it. You want to challenge your brain. So they say that if you try doing a new hobby or a new task, that helps your brain to make new connections in the neurons. So maybe learning a new craft or a new language or a musical instrument, just something that you're not doing by rote. A lot of people tell me, oh, I've done crosswords since I was, you know, 12 years old. Well, maybe it's really not challenging you anymore. Or, you know, I've always done word searches. I think it's good to try something new. Walking, exercise, staying mentally active, staying socially active. And the other thing is to try to eat as healthy a diet as possible. That being said, I do believe that everything in moderation is okay. You know, if you want your occasional piece of cake, then, you know, have that piece of cake. We want to enjoy our lives too. So I just think we want a balanced diet. And I usually do recommend a Mediterranean diet. So fruits, vegetables, whole grains, lean meats, fatty fish, you know, so that like definitely fatty fish, so fish oil if you don't eat fish. I think these can be very helpful. And you know, avoiding other things, you know, excessive alcohol, smoking. So that's, I think, what is most important. And spending time with the people that we love and that we enjoy is very important. So what other questions do you have for me? I have 10 minutes. I promise I will come back and talk more, but the floor is open to you. What questions do you have? Okay.
Some of these things like prevention work that they advertise.
I'm glad that question came up. So Prevagen, I am sorry to say, but I very strongly believe that that's a scam. Yeah, Prevagen, if you think about it, so they have, I haven't seen a Prevagen commercial in a while, but they used to have these fancy commercials. Actually, no, I have seen it, and it was younger people. They had, like, recently, they have 30s and 40-year-olds saying, oh, it made me more clear. Well, there's this fancy jellyfish thing or something that they supposedly get the medicine from. It is so great and so fantastic. Why haven't any of the drug companies picked up this,
That's true.
whatever it is, and made medications? Our pharmaceutical companies, they do the Me Too drugs. They're always looking for for, a better version of something that already exists, because they can't find anything new. So if Prevagen was real, then why aren't they making it? And also I've checked the claims of Prevagen. They say, oh, in studies, there are no actual peer-reviewed studies. And if you look, some of the bottles I've seen just have graphs with like a curve, but there's no labels on the axis. So, and they have been sued in at least 2 states. So I know that we're all looking for something that's helpful, but unfortunately, Prevagen, I think, is not it. There are other things out there. There are other supplements that are based on evidence, on real things. The evidence may not be super strong, but you know, I'm okay with like turmeric. You know, turmeric can help. It's anti-inflammatory, so it can help the joints. Maybe it can help the mind and the memory also. So I'm not opposed to turmeric. And actually, I think another talk that I could do is just on supplements, because that in of itself is a huge topic. So
Can you take too much turmeric?
yeah, I think so. So I think that I've had patients who have taken too much turmeric and they get stomach upset. It can be kind of hard on the GI tract. And there could be other adverse effects as well. Any other questions?
We were told that Eliquis and blood thinners are not good for brain health. Really?
That's a great one. Yeah, I'm trying to think if I've heard that association, and I think that I have, but it has not been substantiated. It's not been proven. Over the years, there are a lot of different medications that get brought to public attention, that, oh, it may worsen memory, but then it doesn't actually end up coming to anything. Like, for instance, when I first started in practice, I had so many patients coming to me about their statins, because somehow someone mentioned a concern about statins and memory. And that has not been truly substantiated. Long-term use of statins do not cause memory problems. In fact, there have been trials actually looking for statins for prevention of memory loss. It didn't do that either, but the point is, you hear often about different medicines that there's concerns raised that come up in the media that, you know, there may not be sometimes studies happen, but then when they're repeated, they're not substantiated. Yes.
You know, a book that is gonna make available the new COVID shot.
Vaccine?
Yes, so actually, I became aware from Cindy just today that the current existing bivalent COVID vaccines are no longer going to be recommended for use, because there's the newer version that is, I believe, coming out in mid-October.
So actually, it's released by the FDA this week, but it probably won't be available in pharmacies till about mid-October. So it's a new COVID vaccine, monovalent, which means it's a single type of vaccine, and it's focused on a variant of the Omicron, a new vaccine. So they're eliminating any of the boosters that were out there previously. So this will be a new booster, very similar to how they do the flu every year. This is sort of an updated COVID vaccine.
And what do you call it, that vaccine?
It's called a monovalent, which means it's focused on a single type of the virus. So it's called a monovalent. And actually, I'm working on a news that you can use, which should be going out today or tomorrow, just to give everyone that update.
will be available here.
Will it be available at Judson? Well, of course it will be. Yeah, as soon as our pharmacy, absolute, they had just let us know that they thought maybe by mid-October, there's a few more hoops that, the federal government makes people go through.
I just wanna see if there's any questions from Zoom.
No.
No, okay, I didn't want to.
No, but thank you.
To neglect anyone online.
I just heard on the radio about an hour ago on the news program that something like 2,500 CVS drugstores are going to have the new COVID booster by the end of this week. And by next week, the rest of the CVS stores should have them. Walgreens is following next week, apparently. And the other thing they said that I hadn't read before was that the new booster is going to mitigate against long COVID. So it sounds like it.
And CBS.
I'm not sure about that,
Yeah, and if our pharmacy gets it any sooner, we'll get it out. There's a few steps yet, so.
Could we get it both with the flu vaccine, because we're signed up for that?
So the question is, could we get it, when you get the flu vaccine? If it's available, I just don't know if we'll have it by then, so.
Can you take them together?
You can take them together, you can. Many people like to take them separately, but you can.
when the COVID vaccine initially came out, it was recommended not to take it together with any other vaccines, to do it in 2 weeks. But now with the boosters, it's okay to take it together with other vaccines.
No, I actually talked to the CVS pharmacist and they said that they would have the vaccine by the end of September. So you heard the end of this week, I heard the end of September. And they told me that I could take the two together. I've been doing that for the last 3 years, taking the flu and the COVID. I'm here to say I'm alive. So. I know a lot of people said, oh, you know, I got this happened to me and I got COVID from COVID and flu. And that's just poppycock. You can't do that. So go ahead and get both of them because you're gonna need it.
Yes,
Isn't there another,
vaccine.
that is something to do with respiratory?
Yeah, I was waiting for that to be mentioned. So yes, there's the RSV vaccine. RSV is a virus, a cold virus that has been around for ages. It's what causes croup. So it's not like it's a new virus. It's been around, but it would, in terms of availability,
So we've recommended based on the guidance of, the pharmacy, and I think after you and I talked, just that individuals can receive it with consultation with primary care physician, or certainly if we can't reach them,
I'm happy to, I believe you need a physician's prescription for the RSV, which if you're unable to, get a hold of your primary doctor for whatever reason, I'm happy to sign off on.
There was something in the paper that said that not all insurances are gonna cover the RSV. They cover flu and COVID, but not RSV. You have to check with your.
But if you have a history of asthma or COPD or something, they will
go
cover
in
it.
and get it like your flu shot.
So it comes under your Medicare Part D, which is different than the flu and COVID, which are covered universally. But if your doctor approves it and prescribes it, then it looks like it will be covered. But it's under Part D, which is a little bit different.
It's same for the shingles. The Shingrix is also Part D. And there was another one also that was Part D, but I don't remember.
Pneumovax.
Might have been one of the pneumonia vaccine, but Pneumovax you can get,
You don't need a prescription.
yeah, you don't need a prescription for the.
But if you're gonna do the pneumovax, you have to start with this 12 or 13 first.
So
I found out the hard
it's
way.
20 now.
So I did the lower one and the pharmacist said a year later, I can come back and get the 20 or 23.
What is pneumovax? For pneumonia.
So there's, it keeps changing. It really does. Yeah, so there's, a new, pneumonia vaccine called Prevnar. Initially there was Prevnar 13, now, it's Prevnar 20. And, so Pneumovax is a pneumonia vaccine that's been around for many, many years. It was the first one to be available. The current recommendations are to anyone over 65 to get the Prevnar 20. And then, at least a year later,